Hi, my name is Marat Fudim. I'm a heart failure cardiologist at Duke University in the United States. Well, the original trial, the so-called REBALANCE-HF trial, was a study in 90 patients with heart failure preserved ejection fraction that got actually randomized to the treatment of splanchnic nerve modulation, where we ablated the splanchnic nerve on the right side with the intent to treat and reduce the amount of volume shifted from the splanchnic compartment, that's the abdominal cavity, into the chest, as we now believe that this redistribution phenomenon is actually one of the key drivers of cardiac decompensation in patients with heart failure with preserved but also reduced ejection fraction. So that was the underpinning, that was the main trial that was utilized for the specific analysis that we presented at THT, where we, at that analysis, then looked at the so-called stress blood volume. And the stress blood volume is a calculated metric, a functional concept of the shifting of blood. When I present on this topic, I demonstrate this bottle that one squeezes. The method of decompensation is that blood gets shifted from the periphery to the central compartment, their heart and lungs, through the squeeze of the bottle. And that squeeze is the sympathetic tone. That's the stress applied to the system. That is the nerves, the splanchnic nerves that we ablate. Thus, we should have less of the blood shifting to the top of the bottle. Well, that's what we refer to as stress blood volume, SBV. So now one can measure it with very, very labor-intensive techniques, or we can calculate that from invasively obtained hemodynamics during rest and with exercise, and that's exactly what we did. So, very good question. We have done a number of clinical studies. There's been a series of single-arm, open-label studies in the United States and in Europe where we did either temporary blocks of the splanchnic nerve, such as with percutaneous needle approaches, where we literally just apply anesthetics. It's been 3 or so studies of that nature called splanchnic-HF 1, 2, and 3. And then there have been some European-based clinical trials where a dedicated catheter system was used. That is now commercially led by a company called Axon Therapies. A dedicated 8-9 French catheter was developed that goes into the azygous vein and utilizes the proximity of the splanchnic nerve that crosses the T10, T11 intercostal vein. Those veins are coming off the azygous vein, thus you can access it pretty easily that way. So there have been another 2-3 single-arm studies that were validating this technology primarily for its safety purposes in patients with HFrEF, HFpEF, and some additional interesting work done around confirmation of technical success. Actually confirmed that they're burning the nerve that they're proposing to burn. So that data is all single-arm open label, but the REBALANCE-HF study, which randomized 90 and had an additional 26 patients that were introduced into the trial in an open label fashion, that makes it really the largest randomized feasibility study ever done in the space of HFpEF for device-based research, to be honest. And that really summarizes where we are. So having said that, the REBALANCE trial itself, which was the feasibility study, they tried to find out who really benefits from this mechanism of reducing the stress blood volume. Well, that trial was all over in an unselected broad population of HFpEF patients was actually neutral. There was no statistically significant benefit on either hemodynamics or quality of life, 6-minute walk test. However, the big positive of the trial is that a subpopulation of patients that did respond was now identified, and that's a population we'll be moving forward and doing additional randomized control trials in. I think it's important to acknowledge that when we looked at the secondary analysis specifically to the stress blood volume, we used a subpopulation only from centers that utilized metabolic cards and were able to actually record cardiac output with rest and exercise very accurately. And that was done for the reasons that when you want to calculate stress blood volume using the Harvey model, it's a pretty well-established model to calculate the stress blood volume and unstressed blood volume. In order to determine that, you needed invasively measured cardiac pressures, pulmonary pressures, you needed cardiac output. To determine cardiac output with exercise is not trivial in patients that exercise on a supine bike. So we utilized data from the two centers that have been using the metabolic cart, that was Mayo Clinic and Duke, that made a total sample of 28 patients. So about a third of all patients enrolled into the clinical trial actually moved on to the secondary analysis. And the interesting thing is that what we found correlates with prior single-arm experiences. In the past, in a so-called splanchnic 1 and splanchnic 2 study, we actually looked in an acute and a chronic patient population what the amount of stress blood volume reduction was. And there we found something around 250, 300 cc's of stress blood volume reduction acutely in patients that underwent acute splanchnic nerve block. And here in a chronic heart failure population, where the baseline was prior to the denervation with exercise, and then you had denervation at one, and then follow up to the denervation at 1 month. And there we had a very similar reduction in stress blood volume around 300, and both at rest and with exercise, similar to what we found before. So for the first time, we really confirmed that the reduction of stress blood volume is sustainable, whether you use an acute needle-based approach with anesthetics or you actually burn one of those nerves. So that's finding number one. The other interesting thing that we found is actually that everybody responded with a reduction of stress blood volume, whether they had the splanchnic nerve ablation and had clinical benefit. We refer to those as responders, or you had this ablation of the nerve, so you were in a treatment arm and actually had no clinical benefit. You were a non-responder, because those are the two populations that ended up crystallizing out. About 55% of the population saw clinical benefit across multiple domains: 6-minute walk test, quality of life, NT-proBNP, and half of the population about did not. The interesting thing is it didn't matter whether you respond or not. In both populations, the ablation of the nerve resulted in a reduction of stress blood volume around the same amount of milliliters. And that is important because it really indicates that there was a confirmation of technical success, meaning if you burn the nerve, you burn the nerve, and it achieves what the nerve burn is supposed to do. It's supposed to pull blood away from the chest in the abdominal cavity. That's primarily where the unstressed blood volume sits. So you shift the stressed blood volume into the unstressed compartment of the abdominal cavity. Now, not everybody benefited. About 45% of the population actually saw no clinical benefit from this because they had no business getting this type of ablation done. We did not know that going to the trial because we could not look at a patient, we could not look at a human being and say, oh, you got to be a shifter. You got to be somebody who's going to be the bottle squeezer. There's no predictors we had prior to the trial that were able to tell us who that will be till we had this randomized controlled trial. And for the first time, we have the responder and non-responder criteria. I think the take-home messages from this study are really the fact that we have, for the first time, some evidence to suggest that in a chronic fashion, we have a confirmation of technical success, meaning we now, even months out from the ablation, can demonstrate with an assortment of hemodynamics and cardiac output that there's a true physiological basis to what the splanchnic nerve denervation does. Meaning, we burn a nerve. We know that pretty well that we can burn a nerve in this procedure, which is, it's a 20, 30, 40-minute procedure at the longest. But right then and there on the table, you actually cannot tell whether you burned the nerve till you do these type of tests, or you actually, see the patient follow up and look at their symptomatic and functional improvement. But this, for the first time, really has a confirmation of technical success 1 month out that matches what we knew from prior single-arm studies in the US in the acute and chronic heart failure setting. That's one. Two, it actually nicely confirmed that the burning of the nerve is simply not a solution for every HFpEF patient. It would be way too good to be true if burning one nerve would suddenly be helpful to every HFpEF patient, because HFpEF is a very diverse population with multiple phenotypes. And I think the fact that stress blood volume was reduced in all patients that we ablated, in average, but only in half of the population seem to be associated with clinical benefit, really indicates the fact that we need to focus on a phenotype-based approach in HFpEF. So a one-size-fit-all approach, like we were lucky with some other drugs in the past, is likely not going to work. Similar to the concept of, would you give a GLP-1 RA, so drugs like Ozempic, would you give that to somebody who has a BMI of 20 and symptoms of heart failure, preserved ejection fraction? Probably not. You would give it to somebody with a BMI of 28 and greater, or even higher. That is a phenotype-based approach. And similarly here, we're inching our way closer and closer with splanchnic nerve denervation to identifying who the patients are and what those symptomatic benefits might be in follow-up. What we need now is a prospective additional clinical trial to demonstrate in randomized fashion that the responder groups we identified, that phenotype that we carved out with the knowledge of the past years, that we apply this technique now to only who we think are responders and hopefully see the same amount of benefit or even more than we have seen before. And then eventually we will need, of course, a pivotal trial. And that pivotal trial will then hopefully demonstrate hard clinical outcomes, because to date we have shown evidence and benefit in a responder group on quality of life, 6-minute walk distance, NT-proBNP, hemodynamics, but we've never shown at least a meaningful reduction in heart failure hospitalization and death. Having said that, a separate analysis at THT we have done did look at a win ratio analysis demonstrating that there's actually an evidence of reduction in heart failure hospitalization and worsening heart failure equivalents if you look at diuretic escalation. So, if you use the totality of evidence to date, there's certainly evidence to demonstrate benefit in heart clinical outcomes, but you need that in a dedicated, most importantly, powered clinical trial going forward. So I think at least 2 more studies are needed before this could see the end of light as a treatment strategy that is hopefully then also approved for use.